I hope that this series is going to find you getting some helpful and uplifting information as we work towards getting back to dentistry. We've all been affected by this crisis, and while most of us tend to get pretty focused on what we need to do to survive personally and in our own practices, there are some very special people that have really stepped up to focus on what they can do to support their colleagues, you, the members of Santa Clara County Dental Society. And I really want to thank each of the members of our COVID-19 task force who have spent countless hours gathering information, and they've developed innovative ways to share some of this information with members and even beyond. We do have some members from outside of Santa Clara, and welcome to you folks as well. What I'd like to do is introduce individually the members of our task force, again, starting with Dr. Bao Nguyen, who is the president of Santa Clara County Dental Society. I won't do this in order with the pictures, but you can find them. Dr. Steve Beveridge, CDA trustee, past president, and chair of our Economic Relief Subcommittee. Dr. Robert Shorey, editor and chair of the Getting Back to Work Readiness Subcommittee. Next, sir, I don't see your picture up there, but somebody who's done a tremendous amount of work for us on our task force is Candace Roney, our executive director. And thank you, Candace, for everything you and your staff are doing. Dr. Will Perry, Dr. John Pisacani, past president of Santa Clara. Dr. Shakopee Pendrikar, she is the treasurer, and she is also the chair of our Community Connections and Public Health Response Subcommittee. Next we have Dr. Baxter Yang. Baxter is our president-elect, and then Dr. Julia Townsend helped us out as, again, a CDA trustee. Dr. Niloofar Zarkesh, our immediate past president, who's one of our panelists tonight. Dr. Sara Hamed, who you met, as our moderator tonight. Dr. Peter Griffith, another past president of our component. Dr. Nima Masumi, one of tonight's panelists and our board member for Santa Clara. And last but certainly not least, Dr. Nick Nguyen, past president, who's done a tremendous amount of work to help us put this on. And so let me describe the next slide. You kind of see how our subcommittees were broken up. We have our overall task force, but then we have 3 subcommittees, and you can see some of the contributors there. And some are actually not members of our task force. They're not members of our dental society. You see Dan Webster, he'll be presenting tomorrow night. And it's been just a wonderful group, and thank you guys for everything you've done. So the main message that our task force wants to convey to everyone is that we are here for you. We know that you may have listened to many lecture type of webinars over the past few weeks. We envision providing a more interactive communication experience. Kind of makes you feel like it's more of a personal approach. We're meeting as a group of friends, colleagues, neighbors, and we're here for each other. We're sharing our concerns, we're sharing what we've learned, and we're sharing hopefully some great ideas of navigating through this crisis successfully together. There's been plenty of bad news to go around, and while we recognize the challenges are ahead, we want to be uplifting and provide you with a sense of certainty for a positive future for our profession here in Santa Clara County. We want you to know that there is a bright tomorrow out there for us. So now, if you would, just get comfortable, sit back, and join us as we present 3 evenings of collaboration and shared knowledge by some of the best and the brightest in our profession. Let me present a quick overview for our objectives of the 3 meetings this week. Tonight, we have dubbed our preview night. We want to give you an idea of the meeting format, hit on some areas of high concern, and even begin to get into the weeds a little bit around PPEs. More on tonight's agenda in a minute. Tomorrow night, we're going to focus on financial matters. What are the opportunities to survive financially through this and even thrive? There's a lot of information out there that seems to change almost daily. Our panelists have sifted through a myriad of resources to provide you with a condensed version of key strategies to come back strong in dentistry. You'll not want to miss that one. And then finally on Thursday, we'll focus on the clinical aspects in far greater detail, getting your offices safely ready for you and your staff and patients to return. Please remember that we're here tonight to provide you with our best understanding of the key issues. These are things that we have learned through a wide variety of resources. It is important that you understand that the content provided here is for informational purposes only. It's not a substitute for legal and financial services from a licensed professional. So let's talk about tonight. Tonight, we're going to have 4 brief presentations just to introduce subject matter and get our question and answer session going. Dr. Niloofar Zarkesh, immediate past president of Santa Clara County Dental Society, will talk a little bit about the stresses that we're all experiencing. We each handle this all a little bit differently, and the stress can be quite significant for some. She will give us some ideas of how to stay emotionally healthy throughout this period. Dr. Robert Shorey has done just a great amount of research for our task force, and he did it right from the beginning. As I mentioned, most of his subcommittee's work for a safe clinical return to practice will be discussed on our Thursday night meeting. Tonight, Robert will touch on the need for testing in order to protect our staff and our patients. Following that, we thought we would take a little deeper dive into PPEs and N95 masks. Oral surgeon, Dr. Nima Masumi, has thoroughly researched this and will be sharing some very helpful information. But our first presenter tonight is Dr. Natasha Lee. Natasha has been assigned to participate on Governor Newsom's task force for getting businesses up and running in California. Natasha is a private practice dentist in San Francisco. She's also a past president of the California Dental Association. Natasha is a part-time instructor of practice management at UOP, and she serves on the 2 COVID-19 task forces for CDA. Natasha will give us some very up-to-date information from the state task force around when we can expect to return to practice and what CDA is doing to support all of us. And I thank you very much personally, Natasha, for making the time to be with us tonight.
Thank you, Ken. Thank you all for having me. I imagine that this might be the first of several webinars that I will be attending at our local components, but I just want to congratulate Santa Clara on being at the forefront of this and being able to provide this kind of webinar to your members, and being able to have the minds that you've put together on your task force and their expertise, and being able to really try to tackle this, given that there's so many unknowns out there. And because of the unknowns, we are oftentimes having to make decisions with the best of the information that we have available to us at the time, knowing that in an hour we might have more information to go off of. So Ken just asked me to do a brief introduction to some of the stuff that's going on at the state level, and I'll provide that, and then I'll stick around at the end for any questions in the Q&A. So regarding the CDA task forces, there are 2 specific task forces. One is on clinical, just like you have at Santa Clara, and the other is on economic recovery. The clinical task force was the first one that was put into place, and the task force has now been divided into 3 subcommittees. One subcommittee is looking specifically at PPE, the other is looking at aerosols, and then the third one is looking at how do we take the information that comes from the clinical task force and create resources and educational materials and get the word out to our dentists. So that work is ongoing, and those committees are meeting daily. We expect that those 3 subcommittees to come together with some recommendations on Thursday, and then more of that information being communicated out to dentists in California. On that clinical task force, we have Dr. Jay Kumar. He is the dental director for the state of California. He's co-chairing that committee, and it's been great to have him there as a liaison from the California Department of Public Health. So we get an idea of what's going on moment to moment there. Plus we have someone who is representing the CDA voice back to the state level. So then and also on that clinical task force, we have a dental assistant and dental hygienist. We recognize that all of this is going to take a team to get us back to work, and that it's important to be able to share information and share concerns and involve everyone in the efforts to get us back. On the economic side, the economic task force at CDA has an array of dentists who are at different stages of practice, including some of our new graduates who are in situations where they're working as employees, as well as those who are practice owners, and a CPA as well who is dental specific and works closely with other CPAs in the dental world. So I imagine that information from that group will be coming out as information is available. That group, I'm liaisoning between them and the state level. So the governor's task force is on economic and job recovery. So I've had a lot of you reach out to me and say, hey, you know, what about these specific clinical things for the state? And while a lot of that is definitely pertinent to what we're doing at CDA, and we're doing everything we can to get that information to the state, and the healthcare part is a part of the economics, the state level task force is very much focused on economy. And I am one of many, many different sectors that is being represented there. Everyone from, you know, technology to education to labor unions. So it's quite an interesting group. So the first piece of homework that group had us all do involved me submitting a 6-page narrative to the state about what is going on in the state of dentistry during the COVID-19 crisis. And I was able to report such metrics to them based on a lot of the ADA surveys and CDA surveys that we have. And I'm just going to share a couple of those metrics with you because they are of interest. The survey was, and this was collected fairly early on in April, but at that point, nearly 98% of dental offices in California were either completely closed or open to treat emergencies only. Just over half the practices were still paying their employees in some manner or in full. We know that's probably changed now since this has gone on beyond the date that the survey was taken. We heard from our dentists that nearly 20% of the respondents said that they did not think that they could sustain their dental practice if closure lasted until the end of June, and that almost 50% had that same belief that their practice be at risk if the closure lasted through the end of August. So we are trying to get as much survey data pushed to the state so they understand the severity of the situation for dentists, not only as healthcare providers, but dentists as small business owners and employers here in California. So the other things that I'll touch on is that we really are trying to make sure that the state understands that dentistry is essential, and we have been deemed essential. That we need to get back to dentistry not only because of patient health, but also because of what we know about oral and systemic connections and what we know about COVID-19 as far as the susceptibility of our patients who have cardiovascular disease, diabetes, these things that we also are recognizing that we in dentistry play a significant role in helping with. Besides the patient care, we are pushing on the state so that they recognize that the economic stability of dental practices is absolutely at stake, and that the longer this goes on, the more likely we're going to see dental offices close. I've seen estimates anywhere from 25 to 30% of dental offices may close or not return to practice after this. It may be some of our dentists who are closer to retirement who say, hey, I'm done with this. Hopefully the numbers aren't that high, but we're letting the state know that dental care is part of our health care system, and that any decrease in the number of providers out there is going to put a big burden on the state in its general health situation, and filter more patients potentially to emergency rooms and to the medical system, which is not what we need now or at any time. We also are letting them know how important we are as employers. The state really wants to protect small businesses. They want to protect employees, and that we are employees, and we have offices that are closed. We have staff members that are furloughed, that are laid off, and that we need to get people back to work. One of the questions they asked me on the initial questionnaire was, do you anticipate any new jobs being developed after this crisis? And I said, in our sector, no, we already have an absolute shortage. And we already have a problem, and this is probably going to make it even more problematic for us eventually. So, and then also letting the state know that our getting back to work, because it is so critical, it really relies on us having PPE. And dentists were were great citizens in this, in stepping back and saying, we understand that the PPE needs to go to our frontline workers, it needs to go to our hospitals, but once the hospitals and the frontline workers have adequate PPE, don't forget about us. We are still essential healthcare providers, and we need to get back to work. So the governor announced today that they have a source of masks that are going to actually be manufactured. And CDA is pushing multiple times per day and nagging, saying dentistry needs masks. Dentistry absolutely has to have the masks. Some of you may have heard that TDSC at one point, weeks and weeks ago, I mean, it feels like years ago, but it was weeks ago, had been given 1,000,000 N95 masks from the state, and that TDSC actually drove down from our supply warehouse in Reno down to the Central Valley, picked them up, was getting ready to distribute them, and the state took them back because the federal government took a bunch of California's reserves. So we're like, okay, it's when masks are available, we definitely need the masks in dentistry. And because of TDSC, we have a supplier that is able to get those dispersed California dentists in a very quick and easy manner. Those original masks that the state had given us were supposed to be dispersed at no cost to dentists. I don't know the status of the new quantity of masks that may be made available to us, though. So the next question I get is, when can we open? And I wouldn't say next question, it's probably the first question I get. There's no opening date at this point. There are thresholds that the state is putting into place of when they may change recommendations for shelter in place. And those have to do with trends in the hospitals and the ICU department, ability to manage a surge if a surge recurs, how much PPE we have now, and do we have enough PPE to manage a surge if it happens, and then the capacity for testing and contact tracing in the state. So if any of you tuned into the governor's press conference today, you will have heard some more information about 4 stages that he's planning as far as the stages of lifting the shelter in place. And I'm commonly getting questions from all of you saying, well, what stage is dentistry? Are we stage 1, 2, 3, 4? Well, stage 1 is the crisis situation that we're in right now, the emergency situation. Stage 2 is where they're looking at starting to open up schools and education, because they recognize that in order to get our workforce back, they've got to get the kids back to school. Stage 3, they talk about that being more of your gyms, nail salons, hairstylists. They said where people are in close proximity to people. But I don't want you to be fearful that we in dentistry are being lumped in with nail salons and hairstylists. So I'll talk a little bit about that before I wrap up. And then stage 4 being when we get back to being able to go to Warriors games. So with the stages, I want to make it clear that we don't have a mandate in California that says we can't go back to work. Okay, so the information that you've received statewide from the California Department of Public Health, that's a recommendation. The information that you are getting from the CDC regarding postponing elective procedures, that too is a recommendation. However, here in California, we've also got OSHA to deal with. And OSHA in California, unlike OSHA in other states, actually requires employers to utilize CDC guidelines as part of meeting the OSHA guidelines. So while there's no actual mandate, because these are all recommendations, what would happen if dental offices were doing more than just seeing emergency patients at this point? I'm getting that question from you. And the question is, you have to be thinking about, it from a liability perspective. So if you had an outbreak in your office and your staff became ill or patients became ill, then you'd have to be thinking, okay, am I going to be able to really defend myself and saying, hey, I went against the California Department of Public Health recommendations during a pandemic, or I went against OSHA's recommendations to follow the recommendations that are found in CDC. So I want you to keep that in mind, even though there's no actual mandate that says you can't go back to dentistry at this point. We are, like I said, continuing to work on the mask situation. Also, the point of service testing, I'll touch on that just briefly. I'm hearing a lot of dentists say, oh, the American Dental Association told us they don't recommend us doing testing. How dare they? Well, what that recommendation from the ADA is saying that a lot of the testing that's available to us in dentistry right now, and you have to be careful that, yes, we have a lot of vendors who are rushing to peddle things to us right now. A lot of those tests aren't reliable, and a lot of the tests that are available out there are actually antibody tests, and the antibody tests are only going to show you if someone actually has had COVID-19 in the past. It's not going to tell you whether that person's recovered and not a risk for you to treat, nor will it tell you if someone's early on in infection and they haven't yet created the antibodies. So once we get to a test that could be 1, accurate, 2, easy to administer in a dental office, 3, with immediate results, and 4, usable for us because it'll actually tell us whether there's high risk to treat this patient right now on the spot, the ADA is not recommending those tests that are out there, especially since a lot of them are even showing up as gray market products. So PPE, ability to test, ability to trace, ability for our healthcare system to survive a surge are all very important. The last thing I'll say is that with the governor's task force, they're really understanding that healthcare has to happen first if we expect the economy to get back into working order, and that if we rush back and there's a resurgence, that is economically going to be even more devastating to the state's economy than the situation we're already in. And of course, talking with the dental director, we know that if there's a resurgence and any clusters start showing up in dental offices, it may also have real long-term repercussions on our patients as far as trusting dental care and our profession. So we've got to keep those things in mind. And I know that in organized dentistry, we're trying to respond in a science-based manner. We're trying to do what's right. We're trying to do no harm to our patients. We're trying to recognize that we're all healthcare providers and that we've all been trained, but we also recognize that there are people on 2 ends of the spectrum often, many dentists who are saying, I don't believe in this, this is overkill, this is, way overboard, get me back to work. And then we have other dentists way on the other end of the spectrum saying, I'm terrified about going back to work, please tell me what to do, exactly what to do, and spoon feed me. So we're trying to work with all dentists here, recognizing that everyone has different perceptions of this, but really trying to make decisions based on the science behind it, what we know, knowing that there's some information that we do not know at this point, and also knowing that we are having to work with departments like the Department of Public Health, OSHA, and CDC, and that we want to make sure that we're at the table and have a voice with these groups so that when near-term, mid-term, and long-term changes may occur in dentistry, that they're being developed by us as dentists rather than things that are overkill or things that are not going to be really appropriate in our offices or anything that we can actually abide by. So with that said, I will pass it back over to
Well, thanks, Natasha, and thank you so much for spending the time to explain it to us. I'm glad you can stick around because I can already see there's going to be a number of questions for you. What I'd like to do is go a little step back in our agenda and just introduce our fearless leader, Dr. Bao, who's here. I think she had a little technical difficulty, but Bao, let me have you say a couple of words.
Thank you, Ken. I appreciate that. Apologize again for my the beginning introduction I missed. I couldn't introduce Dr. Ken Wallis, our task force chair that I appointed when we formed this task force last month, beginning of the crisis. Thank you, Dr. Lee, for your time, for being here, and for the updates and for what is being done for us. Wow, this is a very interesting year for me as president. I want to thank you, all the task force members, our wonderful staff, Candace, Megan, Eric, Michael, Katie, and Tim, who have worked tirelessly behind the scene and receiving all of your phone calls and emails, and so that we can to keep our task force members in the loop of what's happening. We hear you concern, and I hope that you will find our webinar informative. I'd like to introduce now Dr. Niloofar Zarkesh, our immediate past president, for our next program segment.
Unmute, Niloofar.
Unmute. Hello, everybody, and thank you for zooming in with us tonight. Basically, none of us has seen a pandemic like this magnitude in our lifetime. There's a lot of stress in the air, and we are all feeling it. Through our staff at Dental Society, we are hearing a lot of concerned dentists calling and worried, and wanted to let you know that we are here for you. So we basically made this task force to combat the problem and try to address the issues we are having. There is a wide reaction to stress. Fear, anxiety, and anger are natural reactions to traumatic events. Changes in sleep or eating patterns can happen. Difficulty concentrating, worsening of chronic health problems, worsening of mental health conditions, increased use of alcohol, tobacco, and other drugs, feeling frustrated, social withdrawal, and depression could be a range of emotions that can come with such a rampant problem. Next, please. So as healthcare workers, we already have a stressful and high-risk job. As dentists, we are working in a tight space, in a small mouth, and then we want to make everything perfect, and patients are fearful. They want to jump out of their chair as soon as we are done. And now that we have this new virus coming in and making our job even harder. So fear of unknown at this point for dentists during COVID-19 crisis is a lot. We don't know when we can go back to work, what new regulations will be required when we are allowed to go back to work. Will a vaccine successfully be available soon? Are we, our staff, our families going to be okay? Will be able to properly equip or modify our offices before getting back to work? Then on top of it is financial stresses of no income and loss of self-reliance. Family and health issues can become amplified. And then on top of everything, social isolation is killing us all. So as part of, we will have we wanted to address this. We wanted to have a program on stress management that we are putting it together for next week, and we'll send you the information soon when the details are finalized. Please let us know what other programs you might be interested so we can help you out during these difficult times. Change is hard, but as Albert Einstein once said, in the middle of difficulty lies opportunity. Our hope is that we all stay healthy and strong and beat the stress of this pandemic so we can stay focused on our goals and vision for our future. This epidemic will pass soon, and a new normal will be coming for us, and we will look back at this moment and reflect on it. We hope that we have been able to create new friendships, new opportunities, and even new way of living in this moment of time. Our goal is that by getting the right information, making new connections and circle of trusted friends, we not only survive, but also thrive when we get back to work. So let's reach out, stay connected, take care of each other, and stay focused on the possibilities. The possibilities are immense. Thank you so much for listening, and hope that you enjoy the rest of the program.
Hi, I'm Robert Shorey. I'm your editor. I'm chairman of one of our task force, and I wanted to talk to us about some strategies and things for the future. Shelter in place is a strategy to slow the spread of this virus, but it is not a cure. And so we have to be aware that these things can come back in waves. That's why they're being cautious about changing the shelter in place. But shelter in place is an unusual thing in that it's keeping healthy people locked up instead of quarantining the sick. And the positive thing about this is a new virus. There's a lot of things that we don't know about this virus. And that's the purpose of the shelter in place, is to give us the time to not overwhelm our hospitals and to allow us to understand how this virus spreads and the severity of it and how deadly it is. But I will say, we all recognize this, that COVID-19 and future pandemics threaten our way of life. They really do threaten democracy. There are strategies, though, and I think that we can be part of that. Testing is an integral part of defining who is carrying this virus, giving them the necessary resources to be isolated and taken care of, and getting them out of circulation. I'd like those who are listening tonight to Google the Harvard Study Roadmap to Pandemic Resilience. Next slide, please. I want to talk a little bit about the major testing methods that are available today. There's all kinds of these coming onto the market. Natasha talked about the antibody testing, but I think it's good for us as clinicians to understand something about each of these, because as I watched the president's news conference and different personalities and different perspectives, public health people are very interested in the antibody testing because they want to know how many people got infected and how serious it is and so forth. But as a clinician, I'm interested in finding out who carries that virus. When they come into my office, I would like to invite them to the back of my office, but I'd like them to be virus-free if possible, because if they're not, we have to take these universal precautions that can be pretty daunting, and it changes how we segue back and forth between patients. So PCR testing is an RNA amplification testing. Abbott, Cepheid, Mesa Biocare, Kiostat, those are 4 companies right now that have been approved for use, and they range in timing anywhere from 15 minutes to 45 minutes. But these are point of service testing. It's not a matter of sending it off to a laboratory. It's things that we could be trained to do in our offices. We can help our communities. Next slide, please. So this is a quote from CDA. It said, "The lack of community testing," this is what I'm speaking to, means that each person who encounters a dental office can be an asymptomatic carrier. And this requires heightened and upgraded PPEs and protocols within our office. And right now, we don't know all the answers to this. So I'm asking, this is a call to action that I'm asking. If you haven't already done this, take the time to write your legislators. Read about the different testing methods. You're going to hear a lot of blowback. There's error rates, there's this, there's that. But I'm telling you, if I was sorting out a bag of marbles and I wanted to get it down to a certain color of marbles, I'm going to pick out the odd colors. And that's what this rapid testing will do. It might be wrong 1 in whatever number of patients, but 5 times it'll be correct, and we'll get those people out of circulation. I'll allow people to come into my office. I'll still have some upgraded PPEs, but in a time we will control this pandemic better with this type of testing. So recruit your family members to write, and for your own self, take the time to write. Pharmacists today have been given this right. In some of the Midwest, you can go into CVS and get this test. It's been estimated, as Natasha said, that 30% of small businesses might be put out of work by this type of shelter-in-place strategy. Well, some of them are going to be dentists, unfortunately. Now, I was talking to my older sister, and she's telling me how she got a $1,200 check, and her husband got a $1,200 check, and they're both retired. I look at that and saying how the government sends its resources. If they would have spent that $1,000 for a rapid testing machine, if they would surge the production of these machines, and then it costs $45 a person to get these tests done, I could be seeing patients right away. People could be walking into Apple computers and get tested and know that they could work in that workplace. And the argument against it is that they could go out and touch some object or come in contact with somebody and become a carrier. But I would tell you the way I would use this is I would test, while this is going on, I'd test every patient before they have treatment, before they're invited to sit back in my operatory. So I would know that they're either a carrier or they're not. My office would be clean. So the way I see it, upgraded PPEs plus rapid testing means we get back to work safely. So please take the time, write your politicians, use our democratic government to do what it's supposed to do, represent our interests and our concerns and become educated on these things. You're up, Nima.
Thank you for joining us. I'm one of the board members on this task force, and been scouring for the past 2 to 3 weeks all sorts of scientific journals going all the way back to the 1990s to really try to come up with a a whole body of knowledge for you guys to make recommendations off of and to try to put a positive spin on things. And I'm basically the messenger, as people like to say, and some of you may not like to hear what I'm saying, but A lot of this is really based on extrapolating information from, more recent papers, that are related to SARS and one, and also MERS, and what was done subsequent to those infections. So I'm not sure if any of you have seen this, the ADA interim mask and guidelines, but this is basically a summary page of that. And if you see at the top of this chart, they're basically recommending N95 as being the best way to kind of protect yourself against this virus. Because again, it is a novel virus. There's a lot of unknowns. We still don't understand what is the viral load and what's really needed to infect somebody. Is it just one virus particle? Is it 10,000? There's no way to know that because there's no data on it at this point. That stuff is going to be published at least in a few years, hopefully. And then down below that is their KN95s, and these are all almost the same type of masks, but they're manufactured overseas. But they have actually been certified, hopefully, by the CDC and NIOSH. And all the QR codes that you guys are seeing on the slides will direct you to all these websites. So you can actually pick out to see which one of these masks are actually legit, which are counterfeit, and which are not. And on the bottom is the surgical mask, which is labeled as moderate. And that's what all of us are used to using. But unfortunately, a lot of the data on the research on this type of mask versus N95 has not been done in a dental office setting. And there's ample information and data that shows us basically that dental offices has so much more aerosolization. So looking in more details at N95 masks and different types of surgical masks, and this is basically the layering that happens with these types of masks, you can see there's multiple layers. Surgical masks do not have this type of layering. And an electron microscope, you can kind of see how things look up on a close-up. So next slide. These are, again, verbatim coming from the FDA website. And so you say, if properly worn, right? We know many of us, we're all human beings. We all make mistakes in terms of how we wear equipment. Many of us may not even be wearing this properly. There's always leakage in the side of these things. I have a big schnoz. Everybody's got different facial features. We're all going to have different ways that these masks are going to fit. So they're not ideal for aerosolized virus protection. These are for large particle droplets, splashes, sprays, and those types of things. They do not filter or block small particles. And this is coming again from the FDA. Okay, next slide. Again, this just goes into more detail and more in depth with regards to what types of masks the ADA is recommending. Again, the ADA recommendations are coming from the CDC. Okay. And the recommendation is that the N95 masks, which are NIOSH approved. So if you look in the second column, under the requirements, basically the OSHA requirements is that you have to use an N95 that's NIOSH approved. Okay. Next paragraph. Oh, we went backwards, the other way. Perfect. And all of these documents that have been provided by the ADA, you have to always look at the fine print that's underneath these guys. So I've kind of highlighted in red marks underneath what basically they're saying. So I want you guys to look at the verbiage underneath this and what they're saying when it comes to, liabilities and other things. So there's some important data and information that's in the subtext and underneath all of these posters that have been provided by ADA and CDA. Next slide. This is just basically a schematic of the time before COVID-19 and what we're looking at this point. And that's all you can see. On the right-hand side of the diagram, you see somebody that is basically almost looks like they're wearing a spacesuit. But again, there's reasons behind every one of these recommendations from CDC. So for instance, if you take a look at the face shield, that was not required before, but now they're recommending either a face shield or goggles, because again, we're interested in stopping the droplets that are coming to the face. The other thing is that many of us are used to using the breathable gowns. Now they're recommending that something that's basically soluble proof, something that things cannot get through. So all of us now have to kind of go up to the next level when it comes to gowns. They have to be water resistant. They have to be solution resistant. 2 pairs of gloves. And some people ask, well, why is that? Well, the way it is that in their videos, and we're going to go into much more detail on this on Thursday, there are videos from CDC and FDA that show how to take off your clothing and the protective measures. And the layering of the gloves is to be able to make sure that you take things off without contaminating your mask. Your N95 mask is the most precious piece of equipment. We don't want you guys touching the outside of the N95 with a contaminated glove. And that's the reason for double pairing, basically. And then also, then we get down to the shoes and boots and other things. Again, we're trying to make sure that we're not contaminating ourselves and then taking the stuff to our loved ones at home. Next slide. Beautiful. There's a common practice that a lot of people are recommending, which we're calling basically double masking. And again, this is a new practice because before all this happened, N95s and most masks were one-time use only. You would use it and basically trash it. But what a lot of people are doing is because of the shortage of N95s, some people are advocating putting an N95 on, and then on top of that, putting the traditional surgical mask on to protect the outside of the N95 from splashes and larger droplets and things. The only challenge with this is, I don't know if you guys have noticed, but there are different types of N95s. There are some that have a little valve on the outside of it, and that is supposed to make your N95 mask less humid and more comfortable for the person. But there are some indications that if you're double masking on that type of a mask that has a valve in it, that you may interfere with the airflow of that valve. So if you're going to be double masking, make sure you're double masking on an N95 that does not have a valve on it. So you want to be using the one on the left hand of the screen and not use the one that's got the valve in it. And again, is this something that's been studied extensively? No, because we've just started doing this for the past couple of months. But there's some anecdotal data that's showing us that there may be some interference if you're double masking on top of a valve. Next paragraph. Again, a lot of this stuff, we're gonna give you all the data, citations, and all this stuff on Thursday, but a lot of it's gonna be based on QR codes. So if you just literally take a picture of this stuff, it takes you to the website and directs you to all these documents. The biggest thing that we're recommending, because again, we're getting a lot of reports from members and other people that they're getting materials that are basically either counterfeit, that have not been certified. So our recommendation is that if you're gonna buy any protective equipment, whether if it's an N95 mask, anything at all, go on the website, on the CDC and NIOSH website, and please look for those products before you start spending hundreds and thousands of dollars. Next paragraph. So again, this comes from CDC. There is a way to actually identify NIOSH-approved respirators, and they have specific markings that are supposed to be on each mask. And this is one of the easier ways that you can pick things off that are not legit. Next paragraph. So basically, in summary, and again, this was, I know it was quick, but we're going to go into a lot more detail later this week. N95 masks, we're going to recommend that for everybody, even the front office, because right now, there's lots of research that shows up to 25% of patients that are coming in, they're asymptomatic. We don't have enough testing to keep them outside of the office. So we have to assume that we're going to be seeing patients that are asymptomatic COVID-19 positive. So we're going to be recommending N95s for almost everybody if possible. In the clinical staff, in the clinical setting where we're going to be doing high-speed drills and other types of things where there's extra aerosolization, we want to make sure on top of that we've got those extra layers as shown in the CDC poster, that on top of that wearing gloves or face shields and all those other things that we'll go into more details later. And also they're recommending that we look over one another to make sure that we don't have any exposed skin. So there's a whole set of protocols for everything that we're going to be talking about the rest of this week. And one main thing that I wanted to mention, because there's a big question with regards to sealing and fitting of the N95 masks. We are actually required that every time you take the N95 mask on or off, you're supposed to be doing a self-seal check. And this YouTube video will actually go through that and show you how to do it. So even though you've never been, fit tested for these N95 masks, you can do that actually yourself. And you should be doing that anyway. Thank you so much.
Okay, I would like to thank all the panelists for that great information. Now we're going to open up to question and answers, and we'll go over these questions as some of them might be, there will be some repeats, but also if we don't get to everything today or tonight, we will have 2 more nights to answer your questions. And if your question doesn't get answered for any reason, or if you miss it, please, you can send it to content@scCDS sccs.org, and we will get to them and email you with a response. I would like to also, let me go ahead, excuse me for a second, and we can download, like I mentioned in the beginning, you can download this handbook on our website at SCCDS.org, so you'll have access to this slide information. With that, I'm going to start with the questions. Some of the questions in the Q&A section have been answered. I am going to, the most popular question that's being asked by a lot of people is where to obtain this PPE, such as N95 masks. And Nima, would you like to answer?
Well, I mean, what we're hearing basically is that, I mean, the CDA, TDSC, all the major dental supply companies, Henry Schein, they are all working on the background on this, right? And so you have to think about the supply chain. So the advantage that these larger corporations have is that they have their distributors and their supply chains intact. What we're starting to see in here is that if you go with these smaller companies, that sometimes the supply chain isn't there and they can't really vet for where they're getting their masks from. And so sometimes they're not NIOSH certified. So, you know, we, or my office, we're trying to order everything through Patterson, Henry Schein, McKesson, all the legitimate, basically, dental supply companies. So that's, and again, all of us are trying, and we are working on this. The Dental Society is, CDA is, everybody's working on this. We are trying to get everybody N95s, and on Thursday, we're going to be going through a whole protocol in terms of how to decontaminate these guys to make them last as long as possible. And there's tons of data and research on that, which came as a result of SARS and MERS. So we're going to go into a lot more detail on this. So there is a way to take masks and make it last much longer than just a one-time use.
Like
Yes.
Nima said, we're going to be working to give you this information coming Thursday. There's been a lot of changes in this area. As he mentioned, these were supposed to be single use. So remember that little floppy valve. If you're using that time and time again, there's a little rubber part in there and that gets messed up and doesn't seal. The other thing is he mentioned working with known people that you've had a relationship with has an advantage in this situation, because as friends tell you, hey, I know, you know, Dr. Shorey over here, he's distributing masks. You don't know if Dr. Shorey really got those from a reliable source, but when you've had relationships with people, that's probably your best bet to work with them. The other thing is keep in mind that these hospitals have been really stocking up, and they thought that this pandemic might reach a much greater magnitude than it did. And since it doesn't seem to be going that way, I have a feeling that those masks then are going to start to show back up for us to as a resource.
Also, regarding the N95 mask supply chain, we at TDSC started out with over 60 leads given to us by various dentists and other resources on, oh, check with this company, check with this manufacturer. They might have masks. And of those 60 plus, we've actually narrowed it down to just about 3 when we're actually looking at legitimate supply chains where we can say and stake our reputation as a company on only selling legitimate masks that meet the criteria and that have been approved, so that we're not putting our staff or our patients or ourselves at risk. So I know that people are frustrated with the big suppliers not having them, but that's the reason why they have a reputation at stake. Additionally, the masks that TDSC had originally gotten from the state, the requirement was that the state was going to have TDSC distribute all of those at no charge to dentists across the state, regardless of membership. It was just the state saying, you are our pathway to get these out to all dentists. Now, if TDSC is acquiring masks from a manufacturer, they have a very slim margin and they're not going to be in this to make money, but they're going to have to charge the fees that they charge because of the cost that they have to pay to get these from manufacturers. So prices may at TDSC be very different if you are getting what the state donates to us versus what TDSC might be acquiring from manufacturers.
Natasha, if you don't mind, you mentioned during your talk that you've been working with a group that's working with aerosols, and you may or may not be able to give us some inside information, but could you give us any perspective of what they're thinking about, how they're planning on dealing with aerosols in the environments of our office?
Yeah. I mean, we're seeing that there's just not a whole lot of data when it comes to dentistry with the aerosols. A lot of the data that's out there is coming from hospitals, and we've seen some preliminary information where the particles found deep in the lungs when someone's intubating having a different viral load than those found in the oropharynx. Also, we don't know about how, like Dr. Masumi said earlier, we don't know how many particles it takes to be infectious. And while we're generating aerosols, diluting the virus with that water, does that play a role or not? Nature magazine put out an article about 2-3 weeks ago that said the data is all over the place as far as how long something might actually stay floating in the air. And that's a big unknown right now. But I'll tell you that the state is operating from information that it does linger in the air. So I know a lot of you are asking questions about these extraoral HVE units or the hypochlorous acid as far as being able to fog rooms. All of these things are being looked at by the CDA group, and all afternoon I've watched the aerosol groups inbox just fill up with research and research. So I know I'm going to be up pretty late tonight reading more and more on that for our meeting tomorrow. But we will.
You might talk to Nima because he's loaded up our.
Yeah, I know. I've been making some notes. And I'm like, I think I need to contact Nima about that file that he has. So yes,
I've got a whole library of stuff. I mean,
yeah,
there's a lot of data out there.
Yeah, there's a lot of information. There's a lot of misinformation. I think that when you guys get into your details on like some of the things used for reuse of masks, that there's all sorts of different things to know about UV sanitation. When you're looking at the hypochlorous acid, there's all sorts of different things to know as far as its shelf life when you make it versus what you buy, and the different parts per million, and how long it needs to be on contact with surfaces, particularly for it to be to work. So.
Thank you, Dr. Lee. There was a lot of questions about reusing and how to disinfect N95 masks, and can they be reused or not. You pretty much answered them. Also, Dima will go over more details about this and how to, use these Thursday. So there is a question.
Sarah, before you move on from that topic.
And somebody wanted to scan the YouTube video and they scan the QR code on this slide. So I put it back up. I hope that they got it. And with that, I'm going to go back to our last slide.
Nima showed you how these masks are more sophisticated than they look. They're not just a piece of cardboard. And so when we start putting chemicals on them and UV light and this and that, although they're looking into these, I think there ought to be a question mark by that. And to me, it seems like the safest one, and this is my opinion now, everybody, is the double masking, but then have 5 sets of masks and you take it off and put it in a paper bag and let it sit for 5 days, and you keep rotating these guys. Because I think as soon as we start adding chemicals to it, do you get rid of all the chemical? Is it eating the material? We're in a position where they weren't meant to be used this way, and we're going to have to because there's not enough. But I would consider your methods.
Thank you, Shorey. You're correct in saying that when any CDA guidelines come out, there's going to be guidelines based on things that we know, and then there's going to be a whole category of question mark things where there's some preliminary data out there, but we do not know the answers on.
Thank you. I will move on to there's some questions about reusing of the gowns and whether or not, how often do they need to be changed, and when should we use or change the gowns in between patients, and what kind of gowns can be used?
Again, so this has not been studied that much, because in the past the presumption was that we're going to, every time they're one-time use, you take them, you throw them out. But on the veterinary side and some hospital settings as well, there are gowns that can be sprayed down or even washed and put in a dryer. So, but yes, theoretically, you have to assume that every patient that you're seeing is positive for the virus, so you cannot be reusing gowns between patients. So you're supposed to be taking these things off, either trashing them or decontaminating them and then reusing them later. But yes, but again, no matter what type of gown you end up using, it cannot be permeable to solutions.
Thank you, Nima. There's a question about, is the ceiling air purifiers mandatory or a suggestion? And what is the most efficient air purifier?
Robert?
I think this is a gray area. Most people are looking to hospital grade purifiers. That means that they have a HEPA filter, charcoal filter, and UV light. The unit draws things into itself, and the UV light is killing the virus and molds and things, and the filters are trapping these, and then you have to look at the expense of their replacements. But I don't honestly believe that there is a specific company I could point to and say, this is the right one. I can tell the audience that I bought one called True Sense, but I can't put the stamp of approval on it. I felt I have to do something, and I put them in each operatory. I haven't gotten it yet, even though I ordered it over a month ago, a UV system that I plan to mount near the suction intake of my ceiling, air conditioning, so that as it pulls air in, it's presumably sterilizing it before it goes to the main air conditioner unit. And Jeremy Ueno in our dental society had a whole system that you've talked with Nima, who's created a negative pressure system in his office. And so we're all doing stuff, but I was on a webinar this morning through one of the other large teaching institutions, and their doctors are feeling like they shouldn't have to do anything at all. And they feel justified in that stand. But I think we can all agree, we don't know, but I think we could agree it's probably wiser to take a higher ground and show these things to our patients that we're making our best efforts to keep them safe, and our staff as well.
Thank you, Robert. There is a question about how to pre-screen patients. I know that you went over that on your slide about the 3 types of testing that can be done. They're asking, is there any insurance reimbursement information?
I can take that.
Okay.
So with the economics task force at CDA, one of our big topics of discussion yesterday was just that, as far as knowing how much this crisis is going to increase the cost of doing business in dentistry, for PPE, for facilities, adaptations, and even the possibility of testing. And the question became, what can we do to be able to cover those costs? And the CDA is definitely pushing on insurance companies right and left as far as increasing reimbursement and trying to figure out tactically whether we should be looking at a facilities fee, a PPE fee, or building something into our existing fees, and also trying to figure out how to get insurance companies to consider covering those things. And if they're not covering those things, to not have it as part of our contract that says, sorry, we don't cover it, but you can't pass the cost on to your patient to be able to recoup that. So very, very lively conversation and activity going on in that area, but we don't have an answer at this point as far as anyone who is contracted with a plan being able to actually bill for that. Now, if you're not contracted with a plan, you are able to charge what you want for any procedure that you do in dentistry and adjunct.
I think a talking point might be to our patients that they've been sitting and we've been sitting for a month or more, and the insurance company did not give back their premiums. So I think we can substantiate to our patients why it's legitimate to bill the insurance. The question might be, if we have to do this kind of thing long range, is it sustainable? And can we run profitable offices if we have to maintain this high grade of PPEs?
Along those same lines with the dental benefits companies, definitely conversations regarding extending annual maximums and even extending things time-wise, given that some people that may have limitations on their insurance have not been able to get in for dental care to utilize those benefits. And that's going to decrease the amount of their maximum that they may be able to use in the year because of access to dental care.
Thank you, Dr. Lee. There is another question that says that what are CDA doing to lobby the state or federal government to earmark a percentage of PPE for dentists, and how do we ensure that every one of us can get our hands on it?
So we've been at the mercy of the federal government taking things from the state reserves. And then we've been at the mercy of the state providing the PPE where they feel it's best needed. And again, we do understand the importance of it going to frontline workers in hospitals. But we are very closely engaging with the governor's office regarding the PPE and making sure that when it becomes available, that it's available to dentistries. And like I said, with TDSC and a lot of the other companies, they are working round the clock to try to acquire legitimate PPE.
Thank you. So let me see. There's a lot of questions that are repetitive of, I hope a lot of you already got the answer to your questions. I'm going to see if they have any other questions that we can address.
One of the things that I'm seeing is the question with regards to UV lights.
Yeah.
And that is going to be coming. So again, there are standard protocols with regards to how to decontaminate N95 masks, which came as a result of SARS. And so we're going to be going through the specific guidelines with regards to decontaminating N95 masks using UV light. With regards to decontaminating the entire room or your office using UV light, there's some controversy with regards to that, especially if it's a stationary UV light, because there's always shadowing. So depending on where you put the light bulb, and if you have furniture, desk, chair, other things in the way, there's going to cast a shadow, so that UV light is not going to catch those surfaces. And that's why if you look at a lot of the European countries, Sweden and others, they have actually developed a roaming robot that's got a light on it that literally moves around the room to do something like that. Well, none of us can afford a $35,000 UV light that does that. So we're going to go through all of this on Thursday in more detail. But yes, there is data on how to use UV light to contaminate surfaces and all sorts of other things. There's just no way to go through all of that in one session.
Thank you, Nima. So let's see. Someone asked about the difference between the N95 and N95, and you kind of went over that in your.
Yeah, it's a designation as to where the mask was manufactured. But just because it says it's KN95, it doesn't mean that it's a legit N95 mask. Every one of those countries that imports those masks into the United States have to get vetted. They have to have a certificate and all sorts of other things. They go through a whole trial basically to make sure that it is up to our American N95 standards before they're able to sell them into the US market. So, and that's why I'm recommending that everybody, please, please, please go on the CDC website, and they have a list of every manufacturer and who has this certificate and who doesn't. So please don't get anything that has not been certified by CDC/NIOSH.
Can I add something to that as well, Nima? I think with the N95, I think before you make the purchase, maybe ask for, have them send you one or two to evaluate it, and then go onto the CDC website and look at it, make sure this is a legit before you make the purchase. Because even myself, you know, I almost had a connection, and I had, the supplier sent me 2 of them. By the moment I look at it, I know it's definitely, this is fake, you know? And I've gotten 2 of them. Also, my wife got me some at the hospital that, you know, the nurses are selling. And I looked at it, and they're also fake. So there's tons of fake one out there. So we have to be so careful before we order 300, 400 of them. And that costs $6, $7. That can be over $1,000. So do not buy anything unless you get a sample first. Look at it, go online, check it, make sure before you make any purchase on it.
Sara, can I jump in? This is Will Perry. Another thing to think about before, some of us are going to our suppliers and we're ordering a bunch of stuff, figuring that we'll send back what we don't use. Well, a lot of these companies, their policy, you need to ask what company you're working with, their policy, because right now I know several of the major companies that are not accepting returns on any PPEs ordered.
That is correct. And I've heard that from multiple sources as well. Anything that can be contaminated, that it's in the packaging and all of that, none of that is a returnable material. You're not going to be able to return any of that stuff.
Thank you. There's a question, Dr. Lee, if you would be able to answer. Specialists like orthodontists are asking, since they don't use the handpiece or high speed as often as we do, what is the protocol for them, and how often do they need to do so change PPE between patients?
Yeah, there's no specific guidelines on like changing out PPE and all at this point. I think that when recommendations are made by the CDA, and you'll see this with some of the other recommendations out there, that they're going to be probably looking at placing different procedures in dentistry into different risk categories. Obviously, the aerosol versus the non-aerosol generating procedures. But as far as orthodontists, we don't have any specific, oh, this is for pedo, this is for ortho, this is for general dentist. I do think, though, that the issue that may be challenging for orthodontists and pediatric dentists long-term, especially, since they have open bays, is the aerosol issue versus practices that have more walls and more closed treatment rooms. So, but again, we don't have any recommendations at this point on anything regarding aerosols and filtration and HVE and all of that just yet.
Okay.
I see a lot of questions popping up about the sampling of the masks. And I think the reason they're asking these questions, they're accurate in that a company who is, sending you something 2 weeks later after you order it, they're not going to give you a pre-sample because everybody's wanting these. Usually the best you can do is, one, do your dealings with, a vendor that you know personally. Even though Nima's correct, you can't return these things, you can at least, work a little bit better with them. Also, some of the companies will put a picture of the mask on their site, and you can kind of compare it to CDC's legitimate mask. But, I look at that situation, say, still, people know how to stamp the thing in the right place to still make a counterfeit mask. So it's a tough situation right now.
Can I add something to that too, Robert? Yeah. Is from what the news I read this morning, talking about especially the N95 mask, places like China where they make the KN95, they have nationalized their export of their mask, unless we're a big company like TDSC who can order a huge, million mask from it, then you can get out of the country. And a country like Vietnam, who now, 3M and DuPont are making them, they also nationalize it. So we cannot get it out. If you have family member in China or in Vietnam, you think that you can get them out, the family can even ship it out for you. That's the problem right now. So that's where it's showing at this point. So it has to be a big company like TDSC who can order it for us, and we can get it directly, or Pearson, those companies, to get the legitimate N95.
If I could just add, Sarah, to this discussion, I'm seeing a lot of requests here for lists of where we can get PPE supplies and make sure that they're genuine. And seeing that, I think that's a good challenge for the task force to work on. I think we'll, just because your question may not be answered today, know that we're going to take all these questions back to the task force, get them to subcommittees, and see if we can answer some of those requests.
Thank you. There seems to be a question and confusion. Some people are asking that regarding the shutdown or keeping the office open. They're saying that Dr. Lee said that is a recommendation versus the public. So county public health is issued as a mandate. Would you please clarify?
Yeah, so the statewide information from the California Department of Public Health is a recommendation. It's not a mandate. It is not like the state of Nevada, where I understand that if a dentist is violating an actual ordinance that says you cannot do these things, that the board can cite you with unprofessional conduct. However, we did talk about how if there is some liability issue in your practice with your patient or with your staff member getting sick, then it's really hard to justify saying, oh, I went against the CDC, OSHA, and State Department of Health recommendations on this. Now, when the governor spoke today, he was also talking about how once we get to the next stage of the shelter in place, that he's going to be more lenient with regional, county, local recommendations coming from those public health departments. So you have seen some recommendations from some counties where they're getting ready, or they are loosening up the recommendations regarding emergency only dental care. And you are going to have other counties where they're probably going to be later to respond to saying, hey, we are no longer recommending just emergency dental care. And so that's really based on the fact that there's a lot of different levels of disease prevalence in different counties and different areas in the state. Obviously, in the more rural areas, there's less disease prevalence. And so some of those counties may be changing their recommendations sooner than that would happen here in the Bay Area. And places like in San Francisco, that might be happening later than it happened, say, in Orange County, that I understand is also looking at loosening up guidelines. So the governor has said that, yes, there's statewide recommendations, but once we get into this next stage, that he's going to be giving more leeway to some of the local departments of public health in making recommendations to their particular counties and cities. So, I know that is confusing sometimes, because I know that out of Modesto and Santa Barbara, they were getting different recommendations from their counties than they were getting from the state. And of course, I know that if the state opens things up, those of us in the Bay Area who have leadership that is more conservative with our approach to opening up may be feeling like, wow, other people are opening and we're not. So definitely look to what your counties are saying as far as whether things are recommendations or whether things are absolute mandates. Look for state guidance right now until you have something coming from your county, but also recognize that besides the Department of Public Health, we are under guidelines and mandates from OSHA as employers, and that's there to protect employees, and that's administered at the state level. And those, our OSHA in California requires that we follow CDC guidelines.
Thank you, Dr. Lee. While I have you on the mic, can you also, there's a question, can you tell us why dentists are, what phase they are and compared to salons, for example?
So that's what I was talking about earlier, that there's no phase. I mean, there's these 4 stages that the governor laid out today, but to me, the way to look at it is that dentistry falls into all 4 of those stages. We're in stage 1 right now. We're deemed essential. We're providing emergency care only, which means we're active in stage 1. Stage 2 guidelines for dentistry might be loosening things up. Stage 3 might get us back to more routine preventative hygiene care. Stage 4 means we're all going to be seeing each other at CDA Presents in the fall. So, you know, it's not where we're saying dentistry is one stage. And I know there's that fear that when the governor's office made that presentation today, they said, oh, stage 3 is nail salons and hair salons where, you know, you're in close proximity to clients. And, oh, wait, does that mean dentistry because we're in close proximity? No, it doesn't mean that dentistry is going to get lumped in with hair salons and nail salons. We're already in it in stage 1 right now with emergency care only.
Hey, Sarah, there's some.
Sarah, can I jump in?
Let me just comment. There's been some questions about financial things. I just want to remind those that have those questions. Tomorrow night's program will try to cover all the financial questions and things like furloughing our staff, sick leave, and some of these questions.
Sarah?
Thank you. Yeah. Yes, Will?
Yes, Will. A lot of these questions are addressing the uncertainty with some of the answers that we're giving or posing. And the reality of it is, until OSHA comes out with something, there's not going to be any hard lines on some of these questions people are asking. And I know OSHA is working on it. Heard they're trying to get something out by April 30th. I don't know if that's going to happen, but the answer to a lot of these questions is going to be in the guidelines from OSHA at the end of the day.
Thank you. Thank you, Will. Dr. Shulkapi Pendekar wants to make a comment. Go ahead, Dr. Pendekar.
Hi, this is Shakubi. I just wanted to also add on to what Natasha said, and she mentioned this earlier. I mean, even if there are just recommendations, of course, OSHA plays a part in it, and there's a public health mandate. But the issue of liability, and if someone, you know, if there ends up being an outbreak in an office or somebody gets sick or dies, worse, I mean, that, you know, how does that come into play? And you would probably be held accountable and liable to a certain extent if you're providing care outside of those guidelines or those, you know, emergency type of situations that have been recommended now. So just wanted to get that out there as well. Thank you.
Thank you.
Sarah, there was a question by Dr. Pezzacani. I'm just going to go over it if you don't mind.
Yes, thank you, Dr. Zarkesh. Go ahead.
He says, what about the study that says there is no statistical difference between N95 and level 3 mask with regard to healthcare workers actually getting a respiratory illness? Anybody wants to speak?
Yeah, so again, I've looked at, and there's a lot. So again, everybody likes to cite that paper, but what they don't realize is that where was that testing done? The testing was not done in a dental setting. So, and there is lots of papers that's talked about the poor quality in dental offices. So you can't really apply that to the settings that we're going to be working in, unfortunately. And that's a very hard study to accomplish. So if you think of it, who is going to volunteer for that type of study? You know, something that this deadly. So unfortunately, the clinical data is not there, but you have to almost extrapolate a little bit. What is the error typically like in a dental office? And again, there is 50 to 60 papers on that and how that study was done. So we have to look at the whole body of literature, not just one specific study. And that's what everybody's kind of pointing to. And then I always like to kind of think of it this way. What is the downside of being overly protective in situations like this, especially when we're talking about a novel virus where we don't know much about it? Because let's say a loved one, your staff member, or you get sick, you bring it home, and then you're going to be, man, maybe I should have done more. It's that could have, should have, would have. So I think we need to be a little bit overprotective in a situation where there's a lot of unknowns than to just go back to our old ways of doing things with surgical masks. Because again, the body of evidence it's coming, because we see it. There's papers that were published in China. Now there are papers coming out of Italy, Spain, England, pretty soon as United States. It's going to show us that we better kind of be a little bit more protective in this type of situation and to kind of back off on things. So I hope I answered that question.
Yes, thank you, Nima. Dr. Lee, I think this question will also be helpful if you would answer. Somebody was asked, and I had this question and I just lost it. I'm sorry about that. Give me one sec. So they're asking who's going to take care of the cost of the extensive use of PPE gear and the loss of productivity resulting from the time required for PPE gear replacement from patient to patient.
Yeah. We spoke earlier about the possibility of having some reimbursement through dental plans for that. We've also talked about how dental offices may decide that they need to carry on a facility fee or PPE fee to their patients, or just needing to increase the cost of dental care in general. There's even talk about, okay, are there any state subsidies that we can get for testing for PPE, for any modifications that we're going to need to make to our practices? But in the big scheme of things, this is affecting so many industries, especially small businesses, and we're just one sector of that that's looking for money, that's looking for subsidies, that's looking for ways to deal with our loss of productivity during this time. But I think that when all is said and done, the cost of healthcare is unfortunately going to rise because of this. And again, the CDA is doing, having a lot of discussions about opportunities to work with the state for helping out with that, and also working with dental benefit companies to try to see if there's any thing they can do reimbursement-wise or coverage-wise.
Thank you, Dr. Lee. Okay, let's see. I think we've pretty much covered a lot of the questions.
There's one question that I'm seeing, and I've seen this a few times, with regards to specific recommendations, whether for perio and ortho and those things. There's not going to be recommendations specifically made to each profession or specialty. So you have to almost think of it like, what are the activities that you're doing that are causing aerosolization of the virus itself? And so, like, there's a question with regards to, orthodontic offices. Well, we never, use a handpiece. My question is that, well, how are we removing the composite after you're taking a bracket off a tooth? You're using a handpiece or something to kind of take that off. So now, let's say that person was positive, you have the virus that's airborne now, and we know the data shows that it lives in the air for at least 3 hours. And now the next person comes in, the next patient comes in, sits in the same area, same chair, they're breathing in all of that stuff. So this is how you got to kind of think of it. You have to almost, take the worst case scenario here and almost assume that every patient that's coming in could be positive, and what you're doing procedure-wise to spread that virus in your office environment. And most dental offices are not like hospital settings. They don't have negative pressure, positive pressure rooms. The air is stale. It doesn't move. It doesn't change. So that virus just sits in the air, basically. And everybody that comes afterwards is breathing that stuff in. So one of the things that we're going to be talking about recommending is, what to do to improve the quality of the air in the dental offices on Thursday. So, again, that goes to that question is like, is ortho exempt from this? I really don't think so.
Nima, I think a lot of us feel frustrated that we've been doing a kind of dentistry, and now, we hit a bump in a road and all of a sudden we have to do something different. And we understand that feeling, but it's not the first time dentistry's run into this thing. And, I graduated from school, and at that time I was allowed to practice with just bare hands and wash them up. But with time and the HIV outbreak, we got accustomed to wearing gloves and glasses and masks. And we see the end result is a better standard of care where we don't have 30% of oral surgeons getting hepatitis and dentists are suffering from less problems. And we've seen a benefit to that encumbrance. And right now we're probably looking to extremes in our offices to communicate to our patients. We're going the extra mile, and it'll probably back away from there. But I have to believe we're going to see something positive for those that can survive this, something positive come out of this for all of us, and probably procedures that will keep us healthier.
Thank you, Robert. I would like to remind everybody that in the Q&A section, there are some questions that are asked and they've been answered by our panel. Nima and Robert have been pretty much answering a lot of those questions. So please go ahead and look at those, as you might have those same questions.
Yeah, one thing I'm noticing, Sarah, is people are using the chat thing, even though we talked about that. So
yeah,
they might try to convert over their questions to the Q&A so we can get them queued up, and we'll try to answer them for them. It's hard for us to straddle both of these things going on simultaneously.
Yes, if everyone, if you still have a question that has not been answered, please go ahead and type it right now in the Q&A section, and we will try to address them.
Did anybody put up the slide for the video for the N95 test, the YouTube video? I think somebody wants to. I don't know if that's been.
I did put that slide back on, but I can go to it again. There it is.
Thank you.
And one other thing to remind these people is in the booklet, the brochure that we put together that they can download, there are tons of these QR codes for information. And then Nima also has a ton of information in his Dropbox. I don't know what method you'd use to give them access to it, but I tell you, he's been compounding information. It makes my brain sore.
Well, I get pinged a lot from the different societies and the medical and dental side. So I'm getting stuff from the ENT people, from the anesthesiologists, because, honestly, the mouth is connected to the body. We're every time we're doing something in somebody's mouth, we're doing surgery. I mean, we're surgeons of the mouth. We really are. And so a lot of the things, and there are guidelines coming out on a daily basis. I just saw one today that came out in the ENT journal talking about what precautions they are going to be taking to do mastoid surgery or ear surgery and all sorts of other things. We're working in the same territory. So all I'm doing is just gathering data from all sorts of journals and societies and just putting it all together and just trying to come up with somewhat of a a reasonable recommendation. Is this, you know, the holy grail? No, because we don't have those types of guidelines at this point coming from the top. So we're just trying to help, you know, everybody get through this difficult time, and just to protect, you know, us, family members, patients, staff, and everybody else.
Thank you.
Hi, this is
Dr.
Shakopi again.
Go ahead.
Sarah, would you please put up that slide again where we had the Slack information for the Slack app?
Yes.
Yeah, there you go. So I would highly recommend everyone to get on that one. There's a lot of good information, up-to-date information that's being posted, and you can look through all of that. Just like Robert mentioned, Nima has a ton of information up there, and you can view it at your own, you know, leisure when you have time, and just keep up to date with what's going on. So that's a great resource there for you. Thank you.
Yes, thank you. I was going to go over that slide at the end, and thank you for reminding everyone to use the Slack. It's a platform for communication. It's basically a lot faster and more efficient than emailing and texting. You will have a workspace, which we've already sent you a link, an invitation link on April 14th. So if you find that link, or you can also go to the website on our homepage. It says join SCCDS on Slack, and click on that link. It'll take you to the website, and it would direct you. It's pretty straightforward. You just enter your email address and confirm it, and there you are in the workspace where you can chat and communicate and ask questions under these channels that are created, COVID-19 response. So you can, that's a kind of, we're very ambitious dental society, so we want to bring you the most up-to-date and latest technology living in Silicon Valley, bringing you faster tools to be able to connect. And so that all of our members are active, all of our panelists are active there. So go ahead and feel free to ask questions there or share information.
So just to recap the future here, we have set programs this Wednesday and Thursday. Thursday, we'll be, Nima and I will be reviewing the brochure and going into more details. I want all of us to remember, we're not telling you must do any of these things. We're trying to help you make your best decisions possible. If there is enough demand and we need to hear from you about this, then on the following week, both Niloofar and Nima has a very robust presentation in great detail, and we would then continue the following week to continue presentations in even more detail on various topics. So we need to hear from our members. We're trying to respond to their needs and give us the feedback we need so we know what direction to go from here.
Someone is asking if the Profi Cup creates same amount of aerosol. So are they safe to be used?
I can step up a little bit and then I'll let you, Nima. I watched a thing from Gordon Christensen, and he talked about the accuracy of your high-speed suction. Now, in hygiene, you don't usually use high-speed suction, but if you either relegated an assistant to help the hygienist or have the hygienist use their high speed, you can pull most of that aerosol away with proper high-speed suctioning. But indeed, the Profi Cup does, and the ultrasonic absolutely does.
Yeah, and there is ample papers on this specific topic. So sometimes people ask, well, how do they figure out high speed, you know, is causing this? Because there's actually papers on it. They've looked at every procedure from polishing crowns in the lab and what it's doing to air quality, to Profi Cups, to high speed, to low speed. They have looked at all of this stuff. So that data is out there.
Hey, Nima, I have to tell you a story. I have these TrueSend air purifiers in my offertories now. And I went into my office to fool around making those masks that I showed you in my lab. And I'm pouring plaster and stirring it. And all of a sudden, the thing in the other room kicks into high speed. So it obviously sensed that the air quality changed.
Yeah.
Also, earlier, I know that I saw a question come along the chat here, even though it didn't go through the Q&A, asking who we can write letters to, who individuals can contact. I posted that back in the chat, but I will make that available through Candace so that all of your members, if they want to make any comments, send any letters to Jesse Gilgoff, who is the external affairs representative for the Bay Area region from the governor's office, and also Sonia Angel, who was the woman who was speaking this afternoon with the governor's press conference. I will supply her email address as well.
Thank you.
Thank you, Dr. Lee. We're going to try to wrap up this session, maybe a few more minutes. If we can quickly get, someone's asking about any recommendation on teledentistry platforms.
This is an area that's been actually ramping up over the past 5 to 6 years. So there are, because the HIPAA compliance is the other thing that we have to really think about when we're talking about teledentistry. I don't, off the top of my head, I don't remember the 2 companies, but there are actually 2 companies that have been doing this for the past 5 to 6 years, and they're actually HIPAA compliant. So, and I'm going to go over all that stuff on Thursday, but there are companies that have worked on this. And I know I just got an email from PBHS, those websites, that they're saying that there is this HIPAA compliant. I haven't looked into it and I don't know much about it, but the other 2, they have actually published papers on their method and how they're doing things.
Thank you, Nima. I would like to thank all of our panelists. I would like to thank everybody who joined us this evening. If we did not get to your question, please note that there will be more sessions coming up tomorrow and Thursday. Tonight does not have any CE credit, but Thursday's session will have a CE credit, and we will announce that at the end of the session. There will be a lot of more extensive information about the clinical aspects and all the stuff that we're covering in a lot more depth on Thursday. And with that, I would like to remind everyone, if you still would like to send a question, you can email it to content@sccds.org. And with the Slack app, go ahead and you can use Slack, ask your questions there, and you'll get a very fast response because, like I said, all of us are on there and ready to answer your questions. All of our task force members are on Slack, so please continue the conversation on Slack. We appreciate your time. Thank you for joining us this evening, and we hope to have to see you on our next sessions tomorrow and Thursday night.